today this program is a part of workshop activity that is being done at each of the region meetings for the National Medical Association. So this is our fourth presentation, and we have two types of presentations. One is an open presentation for all attendees, and the second is a focused presentation or discussion where we get in-depth information from some of our colleagues about some of the materials that are used by NIH to try to encourage patients of color in particular to participate in this initiative. So as you learn about the initiative and through the backdrop of clinical trials in minority patients and the Tuskegee incident and all the other incidences that we've had through our history, you will be able to perceive the difficulty of trying to communicate with our patients that this is an important thing for not only our patients to do, but for our physicians to do, to be among those million of all of us who become registered and fully signed up as a part of the database with all of us. So I'm going to begin some of the just basic information, and as I go through this, I'll make a few little comments, but I'm just going to try to keep this moving, and there's some redundancy to it, so if you miss one point the first time, you'll catch it the second time. And Dr. Edith Mitchell, our past president and of the NMA, and also one of the PIs of this particular initiative, will be here to finish up the presentation and to do a question and answer with you. I hope. I know she's in Indianapolis. She's just not in this hotel yet. Right. We do know that. We have. All right. So the future of health begins with you. This is the moniker for the All of Us research program. And the W. Montague Cobb NMA Health Institute has had the opportunity to collaborate with the National Medical Association to begin to inform our members and our constituents about the NIH All of Us program. There's been a lot of discussion prior to this initiative, but this actually was begun in 2015 during the Obama administration. It is a part of the Precision Medicine Initiative, and the thing you should know is that this is well embedded financially and longitudinally in terms of time, and it cannot be eradicated. I need not say more, but this is on very firm footing, and it is a major initiative of the National Institutes of Health. The W. Montague Cobb NMA Health Institute, therefore, is what's called a All of Us influencer. And we are to be educators and we are to be facilitators to get the word out to special populations. We're not alone. Kappa Alpha Psi is involved. The National Association of Black Nurses is involved. National Minority Equality Forum is involved. The National Hispanic Medical Association. Probably over 80 different organizations or entities are involved. But we have a special place, I believe, because of the type of work that we have been doing, and we'll allude to that as we go along over the past period of time. We are now in phase 2. Phase 1 was from October to February 28th. We reported on our activities in phase 1, and phase 2 goes from March until July 31st. At the National Medical Association Convention and Scientific Assembly in Orlando on Sunday, the 12th of August, we will have a report out of this initiative, of all the work that the Cobb Institute has done along with the NMA and the regions, and we also plan to have a white paper and publication which will further illuminate the work that we've done, and particularly some of the unique recommendations that have been made to NIH, which actually are being listened to quite closely. This is supported by a grant from NIH, and this particular activity today is a 1-hour CME accredited program. So you'll receive an additional hour of CME from the National Medical Association for your attendance and participation today. We mentioned that Cobb is an engagement partner. We were chosen initially with 13 organizations to help develop strategies to support the campaign. I've discussed that. So it's grown from 13 to almost 100 different organizations, but our role has been very unique. We have with the grant team, Dr. Edith Mitchell is a principal investigator, along with our president, Dr. Doris Brown. Dr. Rodney Hood, a past president of the National Medical Association, and also chair of the board of the Cobb Institute, is one of the members of the team. Along with me, Dr. Winston Price, interestingly enough, another past president of the National Medical Association, is the Information Technology Director for the Cobb Institute and has been extremely busy and involved in a number of different areas with this project. Tiffany Reed, a research specialist who resides in Vermont, has been helping us with all of the preparation for the documents that we need, as well as the preparations for the research that will take place. And you've met Conchita Burpee, who is a consultant, and she also has been singularly responsible for our focus groups and our leadership sessions, one of which will occur this afternoon. I think we have 12 to 14 of you that will be a part of that leadership session. So what is the All of Us research program? I think the key elements are that a group is being recruited of 1 million or more individuals who live in the United States. It's to develop a national resource of data for thousands of research studies and covering a wide variety of health conditions. So have been at some of our other presentations questions about who can access this data. And to our knowledge, anyone can access this data once the data has been accumulated, that it does not have to be just a particular academic institution. It can be accessed by anyone. And unlike single research studies that have been done in specific diseases, the participants can provide data about themselves over many years. So there's a longitudinal aspect to this study that can help researchers to learn how individual differences in lifestyle, environment, and biological makeup influence health and disease. So what that really says is that social determinants of health are extremely important in terms of developing and looking at this research cohort. And also, there will be considerable consideration of genetic makeup. Who is eligible for the program? It's open to individuals, and this is important, who live in the United States, healthy or sick, and from all communities. Age 18 or older can provide consent on their own. That means that they are mentally competent as well as their age to provide consent, and they at present are not currently incarcerated. That would give the thought that there has been a great deal of concern about including those who are incarcerated in this population, this research cohort as well. In the future, enrollment may be expanded to include children and other special populations. And what may be asked of the program participants? Over a number of years, they will complete online surveys about their health history, lifestyle habits, and environmental exposures. And they may be asked to provide access to their electronic health records, physical measurements, and blood and urine samples. And who may access this collected data? I think this is a key. Participants. The participants can access their own health data along the way at any point in time, along with summarized results from across all of us research program. The participants can access that information, and they can share that information with any providers or institutions as they see fit. The researchers in the United States and around the world may access this data, but only after following strict rules and protocols by all of us. It is totally de-identified data, and that's the way that it will always be. Participants may choose to share this information with their providers, as I mentioned, but all of us will not provide any data or results to providers. So I think this has been one of the questions that many of our participants in the focus groups have had as to, well, what's going to happen with this data and who has access to this data? And the other question is, will this data find its way into the hands of the insurance companies and in any way prejudice individuals and their coverage? And again, this is totally de-identified data, and there is no way that that can occur. So how will privacy and confidentiality be ensured? Numerous safeguards will minimize potential risk to data security and participant privacy. For example, again, the encryption of participant data, keeping participant names and other personal information separate from their health information, and continually testing the security of the system. So this will be an ongoing process of testing and making sure that this is totally secure. Researchers will be required to follow strict rules and protocols to keep participant information and private information secure. So first of all, we should talk about the vision of all of us. What has really been conceptualized, as I mentioned, precision medicine was the starting point for this All of Us initiative, but it was felt that all of us was much more descriptive and much more, shall we say, acceptable to the total population rather than precision medicine. And so that's why the term All of Us is being used for this initiative. Dr. Josephine Briggs, the director of the National Center for Complementary and Integrative Health at NIH, we're going to see a short video, and hopefully the sound I can amplify well enough for you to hear, because we don't have other sound in this room.
The vision behind this whole idea is longitudinal. It is collecting information about people over time. Many of our clinical trials don't have enough people in them for us to say with statistical certainty whether the drug has worked just as well for men as it has for women. We live with the laws of averages. And so there are lots of ways in which we as docs can make a huge difference in a more participatory model for clinical research by having 1 million people who have signed up to be part of the clinical research process. One big thing that comes when you have larger studies is you have statistical power to get an answer. With 1 million people, you might suddenly be able to say, might this be something new that we haven't recognized? So I think we will learn things that we haven't dared guess at. We're going to make it lots easier to get answers quicker for important questions. Something new comes along, say a new infection. We have, our current one is Zika. Well, you can then pull samples that were put in the freezer 3 years ago and say, was this actually already present? It's going to really change the face of clinical research. My real hope for the precision medicine cohort is it similarly builds a cadre of people who are loyal to the study and proud of participating and eager to continue this donation of information about themselves into the future.
The next is perspectives with regard to the All of Us program. And this is a video of Dr. Francis Collins, and we really want you to see this.
So much of what we've done in medicine over the years has not really taken into account individual differences, and this is an opportunity to be part of something historic.
Most studies and most clinical trials have always been with the average white male. So as we start thinking about this in the context of building trust, I think we get back that trust by involving the community. Not saying you come to us or we'll just do things to you. We're going to do things with you and in fact allow that information to be accessible to you, the individual.
You're going to have some individuals that are going to say, yes, good, we're getting in on the ground level of a study. And then you're going to have those that have some trepidations about it. My thing is to bring them aboard and let them know that this is for the greater good for them. We have input, and without input, there's no buy-in. And without buy-in, there's no commitment. Without commitment, there's no success.
Tuskegee happened. We're not trying to hide that or sweep it under the rug, but communities of color will be at a disadvantage if we do not find ways to get by that, whether the focus is asthma, whether the focus is infant mortality, whether the focus is diabetes, cancer or heart disease. Communities of color are disproportionately impacted by them.
It has always been playing catch-up to make sure that they're even getting access, much less minimum service. Low income, underserved, and people of color are oftentimes very generous in giving something if they understand it. And they always do so with the intention that knowing this is not just about me, this is not just even about my family, it is about helping the community down the road.
Being able to bring the Asian American population who is never at the table, not only to contribute to science, but to contribute to our ability to understand the nuances within those populations. I think it will provide a huge national data set so we can ask questions and make discoveries about healthcare that will better their own personal health and those of the communities that they are part of.
Diversity strengthens the science. It could bridge some civil rights issues and inequities in healthcare across all races and ethnicities and culture.
As a community of color, underrepresented, hidden, underserved, what would happen if you were not at the table? It is an issue of equity, and it's an issue of justice as well.
It is important for minorities to be a part of this, or we will again be left with medications that are created for really other populations. I'm hopeful that we will be overwhelmed with folk.
I always look at Henrietta Lacks, one person, one African-American woman that has been so instrumental in what we're learning today. I think as we look at that story, and if we can convey that message in a more positive way, then they can see the benefit of what her life represents. I think it's an excellent way to discover who we really are and our true potential.
Dr. Francis Collins, the director of NIH, has been invited to the NMA convention, and we're hopeful that he would be able to come and speak to this particular initiative. And also Dr. Dara Richardson-Heron will be the Cobb lecturer this year, and she's actually the national director for the implementation of the All of Us program. I'm going to kind of just indicate a couple of things about the launch, and then I'm going to turn it over to Dr. Mitchell, and she will finish out on the PowerPoint and direct questions. The launch nationally occurs tomorrow, May the 6th, and it will occur in several sites, including Birmingham, where I will be, Chicago, Detroit, Michigan, Kansas City, Nashville, New York, and Pasco, Washington. And we will have some NMA members that will be present at the launch at most of these sites tomorrow. And that was very important to NIH, that there would be participation across the country. And so I think that that will be a good thing. And I want to just emphasize a point that Conchita made. What was done, what has been done, is looking at marketing materials, looking at a lot of the information that's been provided, critiquing it, significantly, and we've had many of our physicians who have been very, very critical of some, complimentary of others, and some of the images that will be seen that will be used nationally. And so subsequently, after we did these focus groups, we were asked to come up with materials ourselves that would be totally culturally sensitive, totally original from our constituency. And so part of our second engagement is to come up with those materials specifically for NIH and for the other partners. And so I thought that that was quite feather in our cap, and actually Conchita did an exceptionally good job with the focus groups, as did the participants. There'll be 6 in-person events, Lawrence Day. There will be a national digital event. I think it's at 2:30 Central, 3:30 Eastern time is the time in which this begins. These are some of the images that that you will see with regard to some of the marketing materials. And we've had comments about many of these images. And it just kind of gives you food for thought in terms of what it is we can do as providers to encourage patients to become a part of this large cohort. So if there are 1 million members of the cohort nationally, then we should have at least 150,000. We should certainly have 15% of the population of those members who are African American, and similarly with Latino patients as well. And in order to do that, it's going to require a lot of convincing to make it happen. At present, I think clinical trials show less than 5% African American participation across the board. I'm sure Dr. Mitchell can speak to that eloquently. But we have a real issue, and our clinicians are going to have to make this happen for us. Dr. Mitchell?
Thank you very much, Dr. Morgan. It's certainly been a pleasure to work with the All of Us program over the year. Thanks to everybody for being here today and listening to what we have to say. It has really been an effort, and we've all participated. I actually just gave one presentation in Chicago this morning, so I was able to get here, so thank you. So there are some things about All of Us, and people ask, well, what are you doing? What is it all about? For many of you, you know I've been involved with cancer therapy and genomic alterations in cancer therapy, but this is a much bigger program than just one disease. And there may be there should be and will be individuals with no diseases. And with the genomic profiling and all of the information that goes into the program, you're able to look at your family risk. Medications, will certain medications work in individuals? And I can tell you, I've been working with the drug tamoxifen for breast cancer. I've been working with it for more than 35 years. And we just found out about 5 years ago that there are certain individuals, particularly African Americans, for whom tamoxifen doesn't work. Therefore, it's finding a lot of information. The idea is to move this information forward fast, move the technology fast, so that we're able to gain information about ourselves, about our children, about our families, and therefore move healthcare forward. So there are some questions for doctors, and very important to understand. So first of all, who can join All of Us? Well, it is open to adults, and it will only, at initial meeting, those 18 years and older. are able to provide consent on their own and are not incarcerated. In the future, it is anticipated that enrollment will also include children as well as other populations, perhaps incarcerated. So this is going to be a dynamic process where it's going to be continuously evolving over time. But at the initiation tomorrow, only adults in the United States who are able to consent on their own and are not currently incarcerated. So what will patients be asked to do? And sometimes I'll say, well, they may not be patients. They are participants and volunteers in the program because not everybody will be sick. So participants, and I like to have the word participants. So I'm one of those, Dr. Morgan, who asked for a change in this because many individuals will be participants, will not be patients. But participants may be asked and will be to complete some surveys, share information about their health history, about their lifestyle habits, where they live, environmental exposures over a number of years. And that will help us in many communities. We know that there have been environmental exposures, and you say, in New Jersey, for example, I've been a consultant on a community at Toms River, and everybody knows that there are pollutants in Toms River. They also know that there are pockets of individuals with cancer and other diseases. So we'll be able to put all of that information together to help us evolve into a higher level of healthcare in America. Participants will also be asked to provide access to their electronic health records, to go to local enrollment centers where they can have some physical measurements taken, and to provide the biospecimen that will be utilized for the genomic testing. So mainly blood and urine samples. So all of these things can be utilized. Now, the nice thing about this program is information given back to the participants. So it's not like you're just giving up a blood sample and you never hear of anything. You will be given information back that you can use for your own medical care, that your physicians and providers can use to help you with your medical care. So results. What's going to happen with the results and the data? So this question is, will my patients have access to results and data from this program? And the answer is yes, yes. So participants will have access to their own data, as well as summarized results from across the All of Us. And with the All of Us research program, summary data will be available for everybody, so you can know about the summary. You can know what kinds of things occur in, let's say, African Americans, or perhaps in your locality. If there are pollutants that are thought to be there, you can get grouped summary information from a location where there are thought to be some pollutants or other processes or other problems. All of us will not communicate directly with the participants' healthcare team. So there will be no information that goes into your electronic medical record. There will be nothing that goes to your provider to put in your medical record, but the information goes to the participants, and the participants choose what to do with it. Discuss it with your doctor, discuss it with other family members. That's your choice. So throughout the whole program, participants have a choice in what happens to the data. Okay, next question. all of this information out there, how will we protect patients' privacy? We're all interested in the privacy of electronic and digital data. We've heard about hacking and other people gaining access to this information. And then more recently, we've heard about criminals being found by information of these types. Nobody will have access to this information. I have worked with the system that they are going to use for several years. Early on in its development, the cancer doctors were the ones who had utility of this system. It is absolutely confidential. There are multiple ways to get into the data, and anybody getting into the data must have a specific access, and everybody is vetted before you can get access. So who will have access? Well, some researchers will have general access. And I mentioned a locality that is thought to have some pollutants. So I'm anxious really to see you later, because I've been consulting with communities that have pockets of cancer. So I'll be very interested to get information that might help with that. So the system is set up with safeguards, and there are multiple safeguards at who can get into the system, how you can get into the system, and what information you can get out of the system. Not only that, in using it in my history in terms of cancer information, every time you go into the system, you got to go through all of these multiple walls, and it will tell you when you were last there, so that there are a number of checkpoints. So it's safe. I've already worked with it. So patients' data, the participants' data, it's encrypted. Names are not there. No other personal identifiers. So that, for example, if I need to get something on 100 cancer patients who may have received a certain drug, I have to go through multiple firewalls to get in first. I don't see any patients' names. There are some numbers, and I get a set of numbers, and that's how it works. So this is a very safe system. It has been tested on multiple platforms, and it is safe. So you don't have to worry about somebody else seeing data, or policemen getting data won't be there. So it's safe. Who will be able to access this data? So as I mentioned, the data collected will be accessible to researchers. So for individuals doing research, and you can't just go in and say, I'm doing research. You've got to have some research credentials even to be considered to have access. And then you put in what information you want, that's all you can get. You can't get the other information that would be there. And there will be a team evaluating who applies for research positions and the vetting process, the evaluation process. Then there's another totally different team that generates the numbers that will allow one access. So the researcher's intent must be, one, it must be in the United States. There will be some additional later around the world, and it's to accelerate health research and medical breakthroughs. So there's got to be intent, and you can't just say, well, my intent is to XXX. It's got to be a written portfolio. It's got to go through the vetting process so that people review it and say, yes, this is a reasonable research question. And then you put it with the researcher, yes, Dr. Edith Mitchell can have access to this. She has experience in it, and therefore I can get into the data. There are strict rules for the researchers, as I've mentioned. You have to follow these rules. Can't be an if, and, but, or whatever. Absolutely not. It's got to be specific, and The information you get will be specific, and what you do with that information will also be specific, because somebody is going to come behind you to say, what did you do with that data? So there is a process. It has been used by the cancer doctors for a few years. We have fixed a lot of things with the system, and it works. So this, I think we're going to skip that one. Yeah. This I think is not working. So why are we talking about this? Well, we think there is really strength in collaboration. It's not just the NIH. It's really all of us. It's ours. And for African Americans specifically, you name the top 10 cancers in this country, African Americans have either a higher incidence rate or a higher death rate for every single one. So we've been working with that. We've worked with institutions, our communities, the churches, faith-based organizations. So it's working with whatever works in our communities. What works in Indianapolis might not work in Philadelphia. And I can tell you what works in South Philadelphia might not work in North Philadelphia. So it's collaboration with community organizations, with communities who know themselves, and therefore we're able to make it specific for our communities. So there is strength in collaboration, and you know in your community who and what works. These are some of the organizations that we are working with. You can see the Cobb Institute here, but I've been working with the AMA in this process. I've also worked with the National Minority Quality Forum, which is down here. I've worked with the Association of Family Practice, and these are examples, but this morning I was with the Cancer Organization, and I co-chair the Disparities Committee in that organization. So it had been mentioned, and we were requested to do a presentation to the Eastern Cooperative Oncology Group this morning. It's called ECOG Akron Cancer Research Group. So takeaway things, top things that we need to know. So these are the things, in addition to answers to the questions that I mentioned, takeaways, top things you need to know. Number one, won't cost you a cent. Participation is free. And patients do not need to ask their doctors in order to join. So you don't need anybody's permission, as long as I say it's the adults who are able to make a decision for themselves and who are not incarcerated. So individuals who are unable to make their own personal decisions cannot join at this time, perhaps later. So patients do not need to ask the doctor's permission, but the doctor and the providers, the nurses, the pharmacists, and others are sources of information that you can give your patients, but they don't need your permission. Enrollment. Enrolling in this will not require special medications or special participation such that it involves your health care. The data may be shared with your physician if you choose to. However, it won't affect your other medical care. It won't affect your medical care at all, or be given to your healthcare team. So nobody's going to give this to your doctor and it goes in your medical record. Patients will be asked to complete online surveys. And again, this is where I say we're going to get all the patient information out of here at one time, I think. But I've given the recommendation that we say participants, because not everyone participating in the program will be a patient somewhere. So patients will be asked to complete online surveys. Might be about their health history, medications in the past or current medications, their lifestyle habits, their diets, and the environment in which you live. So this may be information, and this is surveys. These are easy to do. And participants may be asked to provide access to their electronic health records. Again, there is a safety net so that your health records, any information would go into this database that I mentioned to you that is perfectly safe. You may be asked to go to a site where you may have some basic physical measurements, blood pressure, body surface area, and others, and to provide blood and urine samples. If they do so, and participants decides to go to one of these centers, they will receive $25 for their time. Now you ask, what kind of center? What do you mean center? These are places that have expertise in collecting samples. So it could be maybe a Quest or a LabCorp. There are also some other centers in various cities, but it would be a respectable place for collecting blood samples. The program has rigorous safeguards in place to protect data security and participant privacy. I've mentioned this several times. Any information collected and put into this system is safe. Program may last for 10 years or more. So this whole process may work for 10 years. It depends on how quickly we reach that $1 million, I'm thinking of money, huh? Yeah. That million mark. But it's really like the $1 million mark because we want to be able to have statistical significance in order to do this. Now, specimen information may be kept for longer than 10 years. So the data system will not be shut down or blown up in 10 years. The 10-year period is the anticipated period of collection of data, but that data would be utilizable years from now. I've mentioned who could join and how they could join without the doctor's or the provider's approval. But likewise, if you decide at the 5-year point that I don't want to participate anymore, guess what? That's your choice. And individuals may withdraw from the program at any time. So again, it's all controlled by the individual. I've mentioned access to information such that the participant can use their individual information, and that is true. Participants will have access to their own data as well as summarize results. So let's say you're living in North Indianapolis and you think there's something there about people who live there and that it has compromised your health. You can get summarized information from that locality. You can get individual information for yourself. And we hope to be able to find out more about populations, so more about African Americans and the disease processes that we know are very prevalent in our community, and summarize data. So you may have access to that data. And if a researcher does a research study where you think your data may have been included, you can get summaries of that research data. So let's say if you want information on African American women who are less than age 50 and who have certain disease processes, that's how you apply for it, and you can get that information. So that a study I'm working on now is regarding colon cancer. And colon cancer occurs more frequently in the African American community, 20% higher incidence and a 40% higher death rate. And the increase in young individuals with colon cancer really is alarming. So I'm getting information on young individuals less than age 50 who probably would not have had a screening colonoscopy who have developed colon cancer and finding information about those cancers. So that's an idea of what I'm talking about. So let's say if there is someone who is 32 years old, develops colon cancer, and they want to know the summary of the research I'm doing, if it's in All of Us, then they could get access to that. So that's the kind of thing, what I mean by summaries. So a few remarks. First from Dr. Derek Richardson, who was with us at the Cobb Institute Symposium last year.
And given the vitally important role that each of you collectively play in the health and well-being of African Americans in the United States, we need your insight, we need your wisdom and guidance to help us better understand and prioritize the issues that are most important to each of you and the communities you serve. But more importantly, we need the benefit of your knowledge and expertise to help us find optimal solutions so that we can make sure that the All of Us research program provides significant value to your respective communities. You know, the potential for enhancing the health and well-being for all and eliminating health disparities is far too great not to include your voices, our voices, your patients' voices, and the voices of individuals and communities of color all around the country as participant partners in this program.
We can make a difference. So yes, as a group, and you saw all of the other collaborators that we're working with in the minority community, we can make a difference.
We are one nation, one people. When called upon to give from within, we come together and find that our capacity to help others is limitless. Here, we are fearless. What lies inside all of us is more than data. It's life. It's more than insight and medical research. It's vision and honor and compassion. What's flowing through America's veins is its diversity. The next great breakthrough will be found in each and every one of us. And what we find there will unlock mysteries, heal the sick, and eradicate disease. We ask for 1 million individuals to come forward and stand on this landmark in history. We ask America to do, once again, what she has always done. Lead the way forward. We're one nation, one people. But all of us are different, and it's those very differences that will lead to answers for generations to come.
So there's, I know we have time constraints. Dr. Mitchell came up and just at the right time. I didn't get a chance to personally introduce her. All of you know Dr. Mitchell is one of our illustrious past presidents of the National Medical Association. She's a PI on this process and also a co-chair of the research committee for the Cobb Institute. And I appreciate she came down from Chicago from the ECOG meeting because I told her there were things that a bone doctor couldn't answer. And so I needed some help on this presentation today. And she came just in the nick of time. So
also, for disclosures, I am on the National Cancer Institute's CTAC committee, which is the research committee, and I'm on the NIH Council of Councils, which is the advisory council to Dr. Collins. And Dr. Collins actually spearheaded this program. So just transparency in my disclosures.
So housekeeping, then there'll be, I think, at least 5 minutes for questions. So what we want to accomplish is we need all the demographic forms, as we mentioned, so we can pick them up. And also, everyone should have completed the post-test. And so we will just go through that quickly and then have a few questions for Dr. Mitchell, and I'm sure. Then will be time, I think, for the next part of the program. Most cancer and cardiovascular medicines work for the general population with very few differences in effectiveness. True or false? Correct. What percentage of African Americans participate in clinical trials in the United States? 5%. The All of Us research program will be open to all persons, both healthy and sick, living in the United States. Okay, let's go back over this. Here's the thing. Living in the United States, not necessarily citizens. And over 18. So it will be open to all persons, both healthy and sick, living in the United States. So it's true. Well, yeah.
Can be incarcerated.
You are absolutely correct.
So did I do okay?
I even answered that right. Oh my. So that's false. Number 3 is false. Patients who participate in the All of Us research program will receive placebo medications and compensation.
False.
False. Compensation, but not placebo medications. Patients with participating healthcare provider organizations will need to give their consent for the secure transfer of their electronic health records to the All of Us research program. Patients within participating healthcare provider organizations will need to give their consent for the secure transfer of their electronic health records to the All of Us research program. That's true.
That's true.
Participants will have access to their own data along with summarized results from across the All of Us research program. Patients can only get access to their data via their primary care provider's electronic health records or hospital portal.
False.
Persons living in the United States who are not citizens are excluded from the program. Persons living in the United States who are not citizens are excluded. False. You have to reside in the United States. You do not have to be a citizen. Patients may enroll their entire family, including children, to get the most benefit from the participation.
True. False.
Children is a...
Remember I said individuals who are over 18 who can give consent.
Right. And you should know that the Pediatric Society is already advocating to include children, and I'm sure that very soon that will occur because it's vitally important to know about their diseases as well. And so finally, participants are required to remain enrolled for at least how many years? And whenever they wish. All right. Doctor, are there any questions for Dr. Mitchell or for me? You've been an attentive audience. Are any of you in the leadership group this afternoon from 5 to 7? Okay, good. So that will be additional help, and we would also like to thank our colleagues from Detroit for videoing this today, and it's going to be very helpful.
I have one question.
Yes, Dr. McDougall.
So, with the downloading of the electronic medical record, is it a one-time download, or do they longitudinally download information? Because I didn't see whether it had spoke to that.
The participant will choose. So there will be questions about downloads, and you give the authority for that. However, if after 1 year or 6 months, a participant decides that I don't want them into my medical record no more, guess what? It stops. But that doesn't exclude you from the program. So you may be asked to do something, and you say, I don't want to do that. You may be asked to give a blood sample, and you say, I don't want them drawing my blood, but I'll give a urine. That's your choice. So the participant in this program has a choice on what you do, when you do it, and when you decide that you don't want to do it. Yes, ma'am.
Okay, you said in order to access the information, you'll have to have certain credentials, but this seems like it would be a wonderful tool for students, like medical students, PhD students. So are you considering allowing students to have access to this information?
Repeat the question.
So the question is, this sounds like something that might be of value to medical students and others in the medical system. And yes, medical students can have access, but they've got to go through the rigorous process that I mentioned of submitting a request. It must be a research request. In other words, if your child is in medical school and they want to see what happened to my mother, that's not a bona fide research question. So there must be a research question, and those questions submitted will be reviewed by a team, and the team will decide if this is a reasonable request or if it's not. If it's not, no access. So it must go through a process, and in that way, the leadership and administration of all of us will know what kind of research questions are being done. And believe you me, they will follow up on that request and the information that has been generated. Yes, sir.
What type of genomics are being reviewed? Is it just a pan genomic evaluation, or are there certain labs? What are you really concentrating on?
So the specimen will be kept in a repository, and because technology changes, there is no end to the information that could be generated, because technology 10 years from now is going to be very different from the current technology. What we know about disease processes will be different. So they're not going to just use all the sample and run a panel. That will not happen. There may be some panels run at different times, but at this time, that has not been set, and it is subject to change.
Dr. Jackson.
Oh, I'm sorry.
We're late for our program on the other side.
This is two quick questions.
All right, you're the last.
Of the conversations with Facebook with Mark Zuckerberg, has the committee reassessed the access to information relative to the type of questions that he received in terms of the large repository of information and access to a lot of different individuals? And the second part to this question is, for those that are getting labs, is this at the cost of the grant, or are you using other vehicles to pay for the cost of those labs that are being done?
So let's try to answer the first question first. This is not Facebook. So there is not going to be a data repository that somebody can hack or either get access to unless you go through the process. And currently, as I said, many of us in cancer medicine and cancer research have already tested the system. And it works, and nobody else can use it. And if I even try to get into the system, there are a number of things I have to go through, although I am registered, as a researcher in the system. So there are many, not just firewalls, but processes to go through to access any information. It will not be on Facebook, and it will not be on Snapchat or any Instagram. It will not be on any of those, and nobody else will have access to it. The only way to get access is through a process that has been established. And then the next question was, no, the individual does not pay for anything in relationship to this program. And if you are requested blood samples at any time, I know Quest will be doing a number of the sites. Others, there are different places in different cities, but you're given $25, not to pay you for giving your blood, but to allow for the cost of travel to the site. So I don't want anybody to go away and say, well, they're paying you $25 to do it. That's not true. You are given compensation to account for your travel cost to get to the site, because you can't just go to any blood drawing center and say, send this to all of us. It has to be one of our authorized sites with the authorized safety methods of collecting specimen and processing them, sending them to the laboratory, and then the data that goes into it.
Okay. Thank you, Dr. Mitchell. Dr. Jackson, you raised a point, your last point, you said, will the grant pay for it? So I think these are the two take-home points that I have. One, in order to get 1 million participants, all of us in the room need to sign up and be a part of the process. So the providers need to sign up and then tell their patients that we have signed up and therefore you should sign up. Second of all, this is at least funded to the level of $10 billion. And I indicated to you initially that the funding is secure, so that the compilation of all this information, all this is within the process, and it is not of any cost to the participant who signs up. The final thing is, yes?
And also tell your friend, your next door neighbor, my minister is going to sign up, and he has advised others in the church to do so. So you can tell your patients, you can tell others, you can tell everybody.
And if you are in the group at 5 p.m., it will be at room G across the hall. Thank you, Dr.
All right, thank you. So just real quick.